हाउ आर यू मैम? कैसे हैं आप?
फाइन फाइन।
बढ़िया बढ़िया।
बढ़िया तो नहीं, बस चल रहा है।
क्यों बढ़िया नहीं?
Because my mother-in-law expired on 7th.
ओह सॉरी,
So we are busy,
she was
but
unwell.
Sorry
because
to
this
hear,
is
ma'am.
online, so I am joining.
अच्छा,
रियल लाइफ में
ओके शिल्पा, ओवर टू यू।
Okay.
So we should wait for joinees to join. I mean,
नहीं, तब तक शुरू करो, तब तक इंट्रोडक्शन होगा, ये होगा, they'll join in 5 minutes. They've opened the link.
okay.
Nand Kishore, are we ready? Have the people joined in?
मैम रियल लाइफ
We are live. Okay, चलो ठीक है। Shilpa, we
Okay.
can start. Yeah.
Uh, so on behalf of IPEN India Delhi chapter, we would like to welcome to all our esteemed speakers, chairpersons, and delegates for today's webinar on World Kidney Day. It is dietetics dimensions on kidney health. And we all understand like kidney health is a very critical area, and nutrition plays a very powerful role into that, and a transformative role in prevention and cure too. So, I mean, though this session, which is going to be there, we are going to explore more and more things which have been initially been learning also. But I think today's webinar is going to be something related to the practical insights which our speakers going to share. And I'm really happy that my dear friends Sunita and Dr. Nancy, they are going to share for the wonderful the theme chosen for the talk, and that is going to be really interesting. And truly honored to have all the panel of experts from Delhi. We have Deepti, we have Ruchika, we have Prachi, we have Suhani. So, I mean, it is going to be good, adding valuable knowledge to us and experience from there. And I would like to express our sincere thanks to Azura Pharmaca Nutrition also for partnering with us for this webinar and into this new initiative. I mean, this is a very good new educational initiative. And I would request now our President, Dr. Vijay Lakshmi Nag, to open this webinar with her welcome address. Over to you, ma'am.
Thank you, Shilpa ji. Very good afternoon, everyone. Welcome to this special webinar, Dietetic Dimension of Kidney Health, organized by the IAPN Delhi chapter and Azura Pharmaco Nutrition in observance of World Kidney Day. On behalf of the organizing committee, a warm welcome to our speakers, panelists, and all participants who have joined us today. World Kidney Day is a global initiative dedicated to raising awareness about kidney health and reducing the impact of kidney disease worldwide. The kidneys are amazing organs that play a major role in keeping the body clean, healthy by flushing out unwanted waste. They also play a crucial role in regulating blood pressure, maintaining fluid and electrolyte balance, supporting the production of red blood cells, and promoting healthy bones. Since diet is a very important area of concern, today's session brings together experts who will share valuable insight on kidney health, the role of nutrition and lifestyle in preventing kidney disease. We have experienced speakers and panelists with us and grateful to the participants for taking time out of their busy schedule to be part of this webinar. We sincerely acknowledge our hosts for their dedication and continued efforts toward education, awareness, and better healthcare practices. I encourage everyone to actively participate, engage with the speakers, and make the most of this learning opportunity. With that, I once again welcome you all and wish you a very informative and productive session. Thank you. Over to moderator.
Thank you, ma'am. It was really nice to coming from you for this webinar also, and in tough time you've been here. Thank you so much for your encouraging words. So I would like to introduce our chairpersons for the first sessions, and over to the chairperson to introduce for the speakers then. So our chairpersons for the session are our ma'am, Mrs. Anita Jatana, ma'am. She's the Vice President, IPEN Delhi chapter and consultant dietetics with Apollo in the Press Apollo Delhi. And I would also like to welcome our second chairperson. She is Ms. Guljeet Kaur. She's the Chief Dietitian with Fortis Hospital, Amritsar. So over to the chairpersons.
Thank you, Shilpa, and a big thank you to Azura for putting it all together. A very important conference or webinar. And just before we started, we were discussing how difficult this medical problem is and needs very fine tuning in nutrition. Not only just proteins, fluids, electrolytes, sodium, potassium, phosphorus, bone health. I mean, it's very, very huge. So I think the learning process goes on, and we've got a great speaker here, Sunita Rao. She is the Chief Dietitian, NU Hospitals, Bangalore. She'll be speaking on thriving on a restricted diet. And that's really putting it in a nutshell. Thriving on a restricted diet with so many restrictions and yet feel good about it. And also to teach them on how they can actually make their food tasty and wholesome, still prevent the complications. So lots to learn from you, Sunita. Over to you.
Thank you so much, Anita ma'am. Thank you for the warm welcome. And thank you, Shilpa, for including me in this webinar series today. Ma'am, as you said, it's quite a handful to handle anybody who has developed a CKD or who's been diagnosed of CKD. So today what I thought was I would actually be giving an overall view rather than discussing each and every step or guideline. Let's take a bird's eye view of the whole situation and see what best we could do in different stages. Can you see my slides, Shilpa?
Yeah, good to go.
Please make it on the, yes, now perfect.
Yeah, so I work for NU Hospitals, which essentially stands for nephrology, neurology. And we are a cluster of hospitals spread across the South India. And we specially cater to kidney issues and urinary issues. So let's move ahead. So what I was thinking initially was that let us see what exactly we mean when we say a restricted diet. Now, what you see is a normal diet for a healthy Indian population, maybe sedentary, maybe a little active for a normal male person. So this is what we generally expect the person to be taking if they are not working out heavily, somewhere between 1,600 to 2,000 kilocalories, 50 to 60 grams proteins, 25 to 40 grams of fat, and the sodium, mind you, all WHO does restrict salt intake or sodium intake for all of us Indians because we fall under a high risk category for cardiovascular diseases. The potassium, if you look at a normal, if you just take a normal meal and then see how much potassium, just sit and calculate how much potassium it has, the minimum that you get in it could be 3,500 mg. But then if the patient, if the person is having a very healthy diet with good amount of vegetables, green leafy vegetables, sprouts and all that, a lot of nuts and seeds, if actually they are following a very healthy diet regime, they might be touching 8,000 mg of potassium also. So, it's highly variable. And phosphorus, there is no recommendation as such. Phosphorus is present in plenty in a lot of foods, in everything that we eat. Essentially, there cannot be a zero potassium and a zero phosphorus diet. It would just mean that you give them an empty plate. So as Vijayalakshmi ma'am was just saying, it's not just the making of urine, that it's not just that job the kidney does. It has a lot of complex and important functions and duties to perform. And so you can understand, if even the kidney functions come down by about 15%, 20%, so many of the metabolic activities in the body gets hampered. I'm not going to really go into the detail, but I was just thinking that we often talk less about the phosphorus, calcium, vitamin D, and parathyroid hormone connection that generally goes into kidney disease. When we all know that when the kidney functions are compromised, the phosphate elimination gets hampered. So there's a lot of phosphorus remaining in the blood, and automatically whatever calcium ions, that is the free calcium that is circulating in the blood, is immediately bound by this phosphorus and forms calcium phosphate. So as a result, the calcium levels, the free available calcium levels in the blood dips. Now, when this happens, the job of our parathyroid hormone or parathyroid gland is to maintain calcium homeostasis. So it immediately senses this and releases parathyroid hormone, and the job of that is to leach the calcium or get the calcium from either the gut or the bone and restore the calcium levels in the blood. Now, if we don't kind of look into the amount of phosphorus that somebody is eating who has CKD and is eating a lot of phosphorus, then this entire kind of a cycle, that the phosphorus binding to calcium, then the parathyroid hormone leaching the calcium from the bone, keeps happening in a cycle. And you can imagine how much hit the bone takes. So there is osteodystrophy. The bones become weak, and especially in children, you see knock knees or bow legs very quickly. Now, what is the job of vitamin D over here then? So we know that kidneys are actively involved in converting the inactive form of vitamin D into active form of vitamin D. So when this is not happening, the amount of vitamin D available in the body is less, then the calcium absorption itself is lower, because we know vitamin D is required for calcium absorption. So you just try to understand, I'm just trying to explain just the small aspect of these four things over here are causing so much of peril in the body. So imagine the other things like the acid-base balance, the anemia that is present because of erythropoietin reduction in erythropoietin production. So imagine what the body would be actually going through. So essentially, it doesn't all start at a go. And most often, we see our patients almost when they are in the stage 3 of kidney disease. We all know that CKD has stages 1 to 5, and then each stage has its own challenges. But when we talk about nutrition, it's actually from stage 3 that we have a lot of challenge. In the first and the second stage, essentially, our job as a dietitian is to maintain or manage the underlying diseases, like whether it is diabetes or whether it is hypertension or obesity. So till stage 2, we are actually just managing the basics, but it's only at stage 3, most of the time, I'm generalizing, but it's only at stage 3 that we actively start looking into electrolytes, fluid requirements, and other things. Now, again, why are we so gung-ho about nutrition in a CKD? That is because protein energy wasting in CKD patients is very, very rampant. And as the stages increases, the malnutrition or the protein energy wasting increases. So if you see, when you see here, you can see that people on maintenance dialysis, that is those who have already completely failed kidney and are undergoing maintenance dialysis, are the ones who are massively affected by protein energy wasting. A lot of reasons for this. We'll look at it in the next slides. However, why do the job of a dietitian is so important and at the same time so difficult? Because all these metabolic disturbances in the body are actually pushing the patient towards anorexia, and the protein that even the protein that the patient is eating is not getting metabolized properly. So this whole gamut of metabolic failure and the inflammation and the underlying disease, all this put together, the patient is pushed towards PEW, or protein energy wasting. Now, we always know that when you see a patient in your hospital, you do your nutritional assessment, you check the BMI, and then you categorize BMI as per our Indian standards and say 18 to 22.9 is the normal. But here, when you look at CKD and especially dialysis patients, there is something called the obesity paradox, where if the patient is on a slightly higher BMI, it has been observed that the mortality of the patient actually reduces. So our obese patients do better than our lean patients, to just put it simply. So if you look at it, in patients who are undergoing peritoneal dialysis, low BMI would surely push them towards mortality. And because they are not coming to you like the hemodialysis patients, you're not seeing them regularly. Between two visits, you see that wasting very, very, profoundly. Maintenance dialysis also, it's the same thing. If the patient is obese or a higher BMI, I'm not talking about morbid obesity, but a higher BMI, there is a reduced mortality. And again, underweight, there is increased mortality. CKD 1 to 5, the effect is not very clear. But again, post-transplant, if you see underweight and obese patients, the mortality increases. Now we use this KDOQI guidelines, for which it's kind of our holy grail. We look into it and see what we can do. We start with this, but essentially guidelines are just guidelines per se. Every case matters. Every case is different. So through the stages, as I just said, we are focusing on initially just the diabetes or hypertension. Then through the stage 3, we look into the control of phosphorus and potassium, and then advanced, there is severe anorexia, then there is fluid restriction, and in dialysis, suddenly the whole thing changes and the patient has to start eating more protein. Energy requirements remain the same. They are essentially as we calculate for every other patient in a hospital. They don't change much, but it is essential to see that the patient is eating enough of calories, because otherwise, whatever amount of protein you give, it is being used for energy purpose and it's not used actually for improving the nitrogen pool in the body. So make sure that the patient's portion sizes are sufficient. And now the challenge is that you have people from all parts of India. You have people who are eating millets. You have people who like to eat oats. So the only challenge when it comes to maintaining energy is to see that they are not eating something that is extremely high in phosphorus and potassium. There is this thin balance we have to do, because the whole grains with a lot of bran come with a lot of phosphorus and also with a lot of potassium. So choose grains which are lower in potassium and lower in phosphorus, essentially. And then you have quite a bit, even if you have diabetic patients, you do get some millets like the little millet and the kodo millet, which will cater to this population. And oats in small portions is okay, but again, large portions you cannot give. For the vast population in India, wheat is definitely fine. Only thing is, they cannot be using too much of high fiber or high bran wheat. That is it. So now, this is another aspect where it depends upon the stage of CKD that the patient is on. If the patient is not on any dialysis, then in the initial stages, you look at the amount of protein the patient is already consuming. We all know that, in CKD, there is protein restriction. This is very common. People keep talking about this. Even your patients will tell you that, ma'am, I'm not supposed to eat dal. Ma'am, I'm not able to eat. I'm not supposed to eat dahi. But essentially, how much protein is our Indian population getting? we are already a malnourished population in terms of protein intake. And so rather than, looking at protein restriction, I think the better word to use over here would be protein optimization. Optimize the amount of protein that the patient is eating, especially because 80 to 85% of the people here are diabetics. So if you want to control diabetes in somebody, if you can kind of restrict protein to a great extent, then it doesn't work. So initially, just optimize proteins, don't do over restriction. Dal khani hai, kha sakte hai. Whole grams like rajma, chana, they can definitely eat. Only thing is make sure that it is soaked and the water is thrown away so that we can reduce the amount of potassium to a great extent. Now again, when people are eating cooked food and not raw food, they get less of potassium and phosphorus because cooking, reduces these things. So it's not about restriction; it's about optimization, especially in diabetic patients. When they next move into dialysis stage, because CKD is a progressive disease, and then eventually they are going to enter dialysis stage. And our duty is to see how long you can keep them off dialysis. And for this, actually, optimizing protein is absolutely important because the more number of infections the patient gets, the more number of hospital admissions the patient gets, the sooner you're going to push him or her towards dialysis. And when do they actually fall prey for infections and hospital admissions? When their immunity is low. And immunity is low when they are not taking the amount of protein and nutrition that is required. So increase of proteins, about 1.2 grams of proteins per kg body weight when the patient is on dialysis. And in peritoneal dialysis, the requirement is much, much higher because the fluid that is filled in the peritoneal cavity leaches out a lot more protein than in hemodialysis. So if you just have to summarize, if the patient is on keto analogs, 0.3 grams of protein per kg body weight is what is prescribed because keto analogs will cover up the rest of it. And then aggressive protein restriction is definitely pushing the patient towards malnutrition. So it's not recommended. Balance it. Choose the quality of protein. That is more important. Initially, we all know that the guidelines always said 50% from high biological value protein. But then the Play-Doh diets came in. I'm not going to talk much about Play-Doh because we have another whole talk by Dr. Nancy about Play-Doh diets. But the focus here now, these days, is not about high biological value protein, but it is about mix matching and combining the different proteins with the plant protein in the focus to reduce the uremic toxins and increase the time when the patient is non-dialysis in the non-dialysis phase. I'm going to skip this slide. So we also have this animal proteins and plant protein sources. And as I just said, try to mix and balance these sources rather than sticking completely to either one of them. Optimize the protein for every stage. It's not that the patient is already on in stage 3 or stage 4, early stage 4, so you're going to restrict it highly. The patient may be extremely malnourished. See how you can combine these sources and divide it through the meals and try to maintain a positive nitrogen balance. Make sure that the patient enters the dialysis. See, dialysis to hona hi hai. There is no doubt about it. So, but when the patient enters the dialysis stage in a very, very malnourished condition, that itself is a huge risk of mortality. So in this stages 4, early 4 and towards the stage 5, managing protein is absolutely important along with the other nutrients. So try to give smaller portions, divide it, see how the patient tolerates. Now comes the biggest issue, that is the potassium. The recommendation is less than 1 milliequivalent per kg per day. And as I said, there is nothing called a zero potassium diet. It's just an empty plate then. So let us see how we move and manage these things. So high potassium, definitely the patient will come to you with fatigue, numbness, nausea. And this sometimes we see patients in our ICU or in the emergency wards with these symptoms, and they'll already be undergoing potassium correction. And that is kind of a wake-up call for the patient, because till then they don't realize that what we have counseled them is amounts to that much of importance. So when they get admitted to emergency ward with arrhythmias or extreme fatigue, that is when they realize that, अरे यार, ये potassium तो important चीज है. You have to follow what the dietitian says. So maintain it between 3.5 and 5. There are a lot of studies which say that when the potassium ranges have been maintained throughout the stages of CKD and even during hemodialysis, the mortality rate comes down to a great extent. We all know why dialysis, there is hyperkalemia. Kidneys are not eliminating the potassium that we take. As I said, if we are on a healthy diet, we take 8,000 mg potassium. Now, the challenge for us is to bring it down to somewhere 2,500 mg or so. So that's quite a challenge. So even in the early stages of CKD, if the patient is on ARBs, that is the BP medications, either ARBs or ACE inhibitors, then there are chances that the patient is pushed towards hyperkalemia, because these medications actually retain potassium in the body. So just for this reason of medication, we might have to reduce or look into monitoring potassium intake in their diets. Another reason is that sometimes patients are not on three dialysis per week, but they are only on 2 dialysis per week for whatever reason. So if the gap between 2 dialysis is very high, even there you have to look into the potassium values there. It can go high in between. So as I said, the survival is best when it is maintained at the optimum range. So even during dialysis, try to maintain it less than or equal to somewhere between 4 and 5.5. How do we counsel our patients? Because now we have started our business of teaching how to thrive even in the even on a restricted diet. Now, how do we go about instructing patients for managing their diet, potassium in their diet? So take a series of lab values. Just don't decide with one lab value. Look at the trend as how whether they have been always high, or it was just one out of the test that it showed above 5.5. Then you will know whether it was just one kind of meal that pushed them. There are many other reasons why potassium could go high. Because insulin is very important in pushing the potassium in the extracellular fluid into the intracellular fluid. If the patient is fasting, when there is no insulin in the blood, the potassiums tend to be high on the higher side, because the patient has to eat and the insulin has to be released, and then the potassium is sent into the cells. So fasting samples are always higher in potassium. So you have to see whether the patient's fasting samples are only high, or even later on the potassium is anytime random samples are also high. Then the other thing is sometimes they don't get blood, because these patients are also on fluid restriction. They don't get blood, IV blood, then the nursing staff will squeeze their hand to remove few mm of blood for testing. And squeezing actually causes cell lysis. And when there is cell lysis, potassium again increases in the samples, because the potassium comes out of the cell. So a sample that has been drawn due to cell lysis will have high potassium. So you have to be aware of all this. Then use the food group. Now, when you start counseling the patient, try to break up the food group lists into smaller lists rather than just low, medium, high. When we do low, medium, high category, just 3 categories, you tend to put a lot of foods into a single column, and then the patient doesn't get so much of benefit. But then if you do a low, a very low, a low, medium, very slightly high, or kind of 5 groups like that. The food gets divided between these, and then maybe some people who are not having so much of potassium, risk, will be able to consume more of those foods. So if you just do 3 columns, then a lot of foods get eliminated in that high column. So I hope I'm putting the point across. Try to give as many choices as possible. That's what I'm trying to say. So leach only if absolutely necessary. Even now in India, the mom and even the doctors, when you say that it is a CKD diet, the first thing they start with is leach everything and then eat. You eat everything, कोई बात नहीं, आप सब कुछ खा सकते हैं, लेकिन अच्छा सा ना उबाल के, ज्यादा पानी में उबाल के पानी निचोड़ दिए, पानी निकाल दीजिए, फिर खाइए. So in this process, what happens is a lot of other vitamins and nutrients are lost. So is it really necessary to leach all the foods? We have found that it's absolutely not, and even the guidelines don't actually mandate leaching as the process for every CKD patient. Let me give you statistics. In about 100 patients we have for dialysis, there are only 3 or 4 patients who require leaching on a regular basis. Rest of them do well, even when we kind of divide the list and then give them maximum options, and then we remove the foods that are absolutely high in potassium. So we all know beetroots are really high in potassium. Green leafy vegetables are extremely high in potassium. But then patient wants to eat these things because they think that it is a good source of iron. So you have to, here the catch is that you cannot really provide iron through food, and so you have to counsel them well. So try to give them maximum choices and follow up constantly. That's the key. The sodium restriction, this probably is one of the most important electrolytes which affects taste to a great extent. So the palatability issues are there. Sometimes the patient says they have to cook separately for me, so that's not possible. They don't have time. Then, so all these challenges are there when it comes to sodium restriction. The allowances are somewhere between 2 to 4 grams per day. But this is absolutely important because there are a lot of issues involved. BP, edema, weight gain, all this can be controlled if the sodium levels are controlled well. Avoid salt substitutes. Why? We know that salt substitutes come with potassium and other minerals also, which are not really good for the kidney. Any other mineral is a load for the kidney. So what does the National Kidney Foundation say? It says less than 2.4 grams per day of sodium intake. And when the patient is on dialysis, it is further down to less than 2 grams per day. That for our calculation purposes, 1 gram of salt is around 0.4 grams of sodium. So you can, based on the prescription that the patient is on, you can calculate how much salt you would want to give. But make sure you tell them not to use alternative salts or salt substitutes. Definitely the first line of elimination will be to remove the processed food, and then, not adding too much food at the table. These definitely will be the first line of eliminations. So salt is naturally present in a lot of foods, and when they start eating it at the 4 grams or 3 grams, gradually they get used to. So ask them to add salt on the food separately. This actually increases the taste. So for most of our patients, it works out better. The palatability increases when they actually cook the food with all the spices, but then they add the salt later when they start to eat it, because then the salt taste hits their tongues and then they feel much, much better. Regular exercise is another thing that helps them to maintain their blood pressure along with salt. That's also absolutely important. Fluids, here the challenge is the season also. When the summer comes, then they all start drinking more water, more fluids, more of every kind of, it could be buttermilk or juice and other things. So urine output is the essential guideline for us. It's always 500 ml plus urine output in whatever stage of kidney disease they are. But sometimes if there is a lot of fluid overload, if the patient has gained too much weight, and if the patient has underlying, comorbidities relating to the heart, if it's a cardiorenal syndrome, then the formula is not as simple as urine output plus 500 ml. It might be strict restriction. You have to check with the doctor for that. Make sure you tell the patient that everything that is fluid at room temperature falls under the category of fluids. It could be, a gelatin, kids especially. We find this a challenge in kids because they are not diabetic and they like to eat these candies and ice candies and other things. So everything that is liquid at room temperature has to be measured into the intake allowance that is given. Then, as I said, urine output plus 500 ml. And then beyond that, watch for edema, pleural effusion, or hypertension. What we could do is ask the patient to, maybe suck a small piece of ice if they are not able to maintain their, urge to drink water. So when they are awake and sitting down, they can suck on a small piece of ice, which helps them to hydrate and feel better in their mouth. They can actually take some water, gargle, and throw it out, spit it out to make them feel better. Or they can probably suck on a candy if they're not diabetic, a polo mint or a candy for some time to overcome that, urge to drink water. Especially now, the coming months of summer are going to be really, really tough in managing such patients. So moving on to phosphorus. So as I said, there is no food without phosphorus. It's present in plenty in all across the food groups. What is recommended is 800 to 1000 mg. The KDO-QI guideline says that you keep it at 800 to 1000 mg, but the whole responsibility of the dietitian is to make sure that they eat healthy, get the amount of protein that is required, and the lab values for serum phosphorus remains normal. What happens, I have already explained. If phosphorus increases, then there is this bone disease that is waiting right there. So the sources of phosphorus also actually, impact the amount of phosphorus that is absorbed. Plant proteins or plant phosphorus sources, the absorption rate is very less, 50 to 75%, because there is a lot of fiber in the plant protein. Then the dairy, the consumption, the absorption increases a little bit, 70 to 80. So what we do is, we don't really restrict the ghee, curd or anything like that. What we say is avoid processed dairy. Processed dairy is, they want to, if they are not on dialysis and they eat a lot of chena or paneer, then that has to be monitored. And if they are eating something like khova or milk-based sweets, like which are, made from condensing the milk, that has to be looked into, and those have to be avoided. Animal proteins are a double whammy. One thing is, when they are not on dialysis, they provide a lot of protein. They also provide a lot of phosphorus because the absorption is slightly greater here, 65 to 75%. Now, the worst foods in terms of phosphorus are the processed foods. The processed foods, the additives which are added are all phosphorus-based additives, and 80 to 90% are absorbed here. So again, the first level of elimination in terms of phosphorus are the processed foods like colas or chocolates or any food that comes into a package. Here again, our pediatric population is very difficult to manage, because you tell a child not to eat chocolate, it's like committing a crime, right? So I have already explained about the bone disease. I'm not going to go into this. But the good news is that phosphorus is heat labile. So you cook the food, then you can reduce the phosphorus to a great extent. Especially pressure cooking has shown to reduce the phosphorus to a great extent, whether it is meat or even the lentils. So you soak the lentil, drain the water, you are getting rid of a lot of potassium. Then you cook it in a pressure cooker, you're also getting rid of a lot of phosphorus. So essentially leaching lentils and then cooking it in pressure cooker is something that you can suggest for all your patients whose challenge has always been maintaining serum potassium and phosphorus levels. Egg whites are the best option. Yellow, again, it's not about cholesterol. A lot of people think that when in the counseling session, they say, Madam, aajkal to pura egg kha sakte hain na? Because cholesterol, they have told, the American Diabetic Association has said that, egg yolks don't really contribute to cholesterol. They are all very aware of these because of the WhatsApp. But here the situation is not about cholesterol, it's about phosphorus and also to some extent potassium. Fiber is a game changer because you introduce fiber, it helps a lot of things. It helps in lower absorption of potassium, lower absorption of phosphorus, and it so in low fiber diets, always the uremic toxins are very high. Dr. Nancy will be stressing on this when she does Play-Doh diets, but fiber also prevents dysbiosis. Earlier, in the early stages of CKD, the gut health is quite okay. But as the stages increase, like stage 4, stage 5, they have a terrible gut. Whatever protein you give or whatever food you give, the absorption is very bad because of gut dysbiosis. So try to include fiber. You can choose fiber from low protein and low phosphorus and low potassium options. So overall, what is our aim? You're trying to maintain a balanced diet. You're not trying to go very much away from the balanced diet plate that we all know is good for good health. But you are at every stage going to give them alternatives for protein, which are low in phosphorus, like egg whites, tofu, and lentils that are okay. That is, you don't have to really avoid lentils or anything. You just have to give them portion sizes that they can eat. And in every meal, what is the total amount of protein that they are getting? That is very important rather than eliminating foods. Then potassium alternatives, you definitely have low potassium vegetables and low potassium fruits. If potassium is such a challenge, eventually you can ask them to leach, but otherwise it should be okay. Then fiber alternatives like low potassium vegetables will give you a lot of fiber. Low potassium, low phosphorus foods like, you don't have to give them a whole bran bread or whole bran atta. It can be just a normal atta. There is still fiber remaining in it, and that also helps. Unfortunately, for anemia, you don't have a lot of choice because all said and done, you try to increase the iron content in the diet, the potassium increases. And also we know that iron, low HB levels is not just because of nutritional anemia, it is because that the patient is not able to make erythropoietin, and even if you give a lot of iron-rich foods, you may not be successful. We should know our limitations, and we should be able to explain this to the patient very well. So eventually, if with all the diet modifications and counselings and assurances, if the patient is not able to eat well, not able to consume the required calories and proteins well, then you have to resort to oral fortification in the first line. And for very sick patients in your ICU or hospital with sepsis, tube feeding is another option. We have a very good renal nutrition formula. And then for patients who are on dialysis, intradialytic parenteral nutrition helps. It's a little expensive. It is expensive, but then it is helpful. They may need 4 to 5 sessions of intradialytic parenteral nutrition before you can see the rise in the serum albumin levels. Ultimately, of course, for patients for whom gut is not usable, parenteral nutrition has to be administered. So thank you for the patient listening. I hope I have conveyed the message that the aim is not to restrict, but the aim is to choose what best you can give in each food group and give a lot of choices for the patient. Each patient is different. Everybody may not need the same amount of restriction. Thank you very much.
Thank you, Sunita. That was very well done. A very, very difficult diet, but very well explained. And it was so good. That message was loud and clear, no leaching. I'm so tired of people saying we've been told boil kar do, overnight soak kar do, pani pheng do, and as it is, they're so malnourished, and to have them leaching out everything. So very, very, very clear in everything, including potassium, phosphorus, and what you should actually be looking at, including fluids. My one question to you before the next speaker: do you have these patients complain a lot on constipation? Because fiber
do.
will also work with fluid restrictions.
Yes,
You don't give them fruits, you don't give them fiber, you don't
true,
allow them salads.
true.
So, do you have these
Yes,
major
we do,
problem, and
we
how do you
do.
resolve them?
In fact, that is a big challenge because they are lost. So the only thing we know when it comes to relieving constipation is to eat a lot of fruits and vegetables and drink a lot of water. So it is a challenge for them. And when I mentioned that there were about three of our dialysis patients whose potassium is always on the higher side, and we have to resort to leaching for them. And their potassium, they also have constipation. And as we know, gut actually plays a very big role in eliminating potassium in these patients. And so when they have potassium, they will have hyperkalemia also. So for these patients, what we have done is we have listed the lauki, turai, chocho, and these kind of vegetables. And we have asked them to have it as a separate portion. It's not the regular sabji that the family is making, but there's going to be another additional cup of vegetables, and these are
For them.
also inherently having a little moisture, these vegetables, squash vegetables. So these have helped a few people. Some of them are on prescription fibers. So overall, this is the mode of
Way you handle them
management. Yes.
of this. Yeah. All right. Thank you.
Thank you, ma'am.
So I would like to add that was really very nice, Sunita. Excellent session. And ma'am has asked my question already. I was also concerned about dialysis patient having so much of constipation. And you're absolutely right. We all are on one, platform that these patients on dialysis are so mentally disturbed. And if we tell them no, no, they get so much, the quality of life is very decreased. So we should not say no, no. We should say yes, yes, and no, no. And the middle path, as you explained, is the best one.
It's
That
like
was
walking
excellent.
on a thin bridge.
Yeah,
Yes.
yeah.
Very fine
Hi,
balancing
ma'am.
act. Hi.
Hi, ma'am. How are you?
But yeah.
Thank you. Nice
So,
meeting and listening to everybody today.
yeah.
Nice. Thank you.
Thank you.
Over to you, Guljit, for the next speaker.
Yeah. So our next speaker is just a moment, ma'am. Ma'am, आप ले लीजिएगा डायस 2 मिनट मुझे. I'm on the way to airport actually.
अरे वाह, दिल्ली आ रही हो?
नहीं मैम, बेटी को एयरपोर्ट छोड़ने ही जा रही हूँ. बेटी मैम आप शुरू करिए, मैं साथ में बोलती हूँ. जस्ट मोमेंट में उसका लगेज थोड़ा करवा
अच्छा,
दीजिए.
ओके ओके
Yes,
ओके,
yes.
फाइन. चलो, Dr. Nancy, we are waiting for you to hear more from you. We've learned quite a bit. Now we want to hear from you. Let me introduce her. She's Dr. Nancy Sahani. She's HOD Department of Dietetics, PGI Chandigarh, and she's going to help us to learn something more about the vegetarian diet. So the Plado revolution, plant dominant low protein diet. So all the while we had been saying use non-vegetarian, use the A-class protein. So let's clean up the plate and learn a little more from Nancy. Over to you, Nancy.
Yeah. And now I'm little free. So it's great. Ma'am has introduced you already. So it's going to be a pleasure to listen to you. Thank you.
Thank you, Anita ma'am. Thank you, Guljit. Actually, Sunita has done such a wonderful job. I think she has covered it all, and she has talked about Plado diet as well. But because she couldn't help not talking about it when you were talking about the CKD diet plan and in the Indian setup. And when I was like going through the Plado diet, मुझे तो एक बार ही ऐसे लगा कि ये तो सबकी डाइट है जो हम सब खा रहे हैं अभी, इसमें क्या है? So then I found out that this Plado diet is like that is from the US thing, and they have lots of non-vegetarian food, then that also processed. So that holds true for them. But we Indians, I think we all not like the normal population is already having this diet, I think. So let's have a bit of insight into it. So it's a plant-dominant, low-protein diet for chronic kidney disease patients. So if you, sorry. Mhm. So it's a as we all know that CKD is ninth most prevalent cause of death globally, and progressive kidney damage often leads to dialysis or transplantation. This is nothing is new in this. And diet therapy, of course, plays a conservative management therapy as a therapy of CKD. And recent research proposes PLADO, that is plant dominant low protein diets, as a promising approach to slow disease progression. So let's see why. So because there's a uptake, because as Sunita said in her concluding slides, that yes, fiber, and as we all talked about this constipation thing. So of course, when it is plant dominant diet, so fiber intake will be more, and it definitely will lead to gut dysbiosis correction and decrease uremic toxins. Then there is lower intestinal phosphorus absorption, because plant-based diets, phosphorus is the bioavailability is not good, and because of the phytate content. So there's a low phosphorus absorption, and then there is a lower risk of hyperphosphatemia, then a lower dietary acid load and lower metabolic acidosis, lower glomerular hyperfiltration, and of course it leads to lower proteinuria. And magnesium intake is higher because the chlorophyll, which gives green color to the plant, it has magnesium atoms. So then it might lead to lower vascular calcification. So these are some of the positives of plant-based diets or a PLADO diet for a CKD population. All are well aware of these stages of CKD, and Sunita also highlighted them. Stage 1, 2, 3A, we can divide it in 3A and B, stage 4 and 5. So the estimated GFR, it actually lowers down from a normal 90 to 110 to less than 15 ml per minute. So if we see the global burden of chronic kidney disease, it is the ninth leading cause of death. And in 2023, 788 million people aged 20 years and older were estimated to have CKD, and impaired kidney function is a risk factor accounting for 11.5% of cardiovascular deaths. So again, this plant-based diet can be an anchor to this as well. So definitely the medical nutrition therapy targets for slow progression, reduced uremic toxin production, control metabolic complications, and prevention of protein energy wasting. And the target and the aim is protein restriction, sodium restriction, phosphorus limitation, potassium control, which the previous speaker has actually spoken at length. So high protein intake definitely causes increased glomerular hyperfiltration, increased intraglomerular pressure, accelerated nephron damage. And animal protein, though, is more biologically available, but may increase the nitrogenous waste, phosphate load, and acid phosphate production in the body. And a traditional protein recommendation includes 0.6 to 0.8 grams per kg per day in non-dialysis CKD. Very low protein diets with keto analog supplementation is also there. The core benefit of this diet is to reduce the rapid decline rate of GFR and also help in reducing uremic symptoms, whereas challenges associated with LPD are poor adherence and risk of malnutrition. So what is PLADO diet? It's a type of LPD with daily protein intake of 0.6 to 0.8 grams per kg per day, with at least 50% plant-based sources to meet the targeted dietary protein, and which should preferably be whole, unrefined, and unprocessed. This is consistent with the RD of DPI of 0.8 grams per kg per day, which has a high safety margin based on established metabolic studies. The lowest DPI requirement to avoid catabolic change is 0.45 to 0.5 gram per kg per day, and it has been suggested that more than equivalent to 50% of dietary protein intake should be of high biological value with high GI absorbability to ensure adequate intake of essential amino acids. Now here comes the challenge in the Plado diet. So I'll come to the next slide because Plado diets are also various diets. So see, there are some plant-based proteins which can have an essential amino acid profile which is whole or complete, like soy, tofu, chia seeds, buckwheat, then temph, amaranth. So all these have to be then judiciously included in such diet plans. That is very important. So a low protein diet plus which is plant dominant, that is more than 50% becomes a Plado diet. The principles remain the same. Sodium less than 4 grams per day, less than 3 grams if edema or hypertension. High fiber, more than 25 grams per day, adequate energy. And the hard endpoint targets are slowing CKD, delaying, preventing kidney failure and dialysis, improving cardiovascular health and improving survival. And the patient reported outcomes should include quality of life, uremic symptoms, diet palatability, dietary adherence, and safety and tolerance is like, the serum potassium levels have to be in check, the glycemic status, because, when it is a plant-based diet, then might be the refined cereals are more. Then, of course, the nutritional status, the muscle wasting, again, talking about the quality of the protein, it is very important. Else, there will be muscle wasting and the overall functionality and frailty of the patient. So if you see the benefits and challenges, the benefits include lowering intraglomerular pressure, synergistic effects with RASI inhibitors and SGLT2 inhibitors, then controlling uremia and delaying dialysis, preventing cardiovascular harms, less absorbable phosphorus because with high brands and with this thing, only approximately 30% of the phosphorus is only absorbed. Lowering acid load with less acidogenicity, high dietary fiber enhancing GI motility, favorable changes in microbiome, and less cardiac health disease markers, and less inflammation and oxidative stress. And the potential challenges are risk of protein energy wasting, inadequate essential amino acids, undermining obesity management, high glycemic index, as I already mentioned, high potassium load and hyperkalemia, and low palatability and adherence. Now, if we see the composition, so the domination will be of legumes, soy, as I already mentioned, soy products like tofu and temph, nuts and seeds, whole grains, and some grains which are which have essential amino acid profile, good essential amino acid profile, and vegetables and fruits and limited animal proteins. So if you see the different types of plant-based diets, strict vegan, like exclusively plant-based diet excludes any form of animal origin. This actually is not even recommended for a normal person. Definitely he or she will suffer from micronutrient deficiencies as well as essential amino acid deficiencies. Now, vegetarian diet that avoids meat and fish but includes dairy products and eggs. Most of the Indian population might fall in this because we all have milk and milk products, and eggs definitely some have and some don't. And then this is pescatarian diets that privilege plant-based foods but includes dairy products, eggs, and seafood. Now, this is not Indian because it is not in an Indian origin. Maybe in some west side of India, but not here in north side. Then lacto-vegetarian, similar to vegetarian but exclude eggs. Now this is like 100% vegetarian diet of Indian diet because milk दिमाग में नहीं आता कि ये non-veg है. So everybody has milk and milk products who claim to be pure vegetarian. And ovo-vegetarian, similar to vegetarian but excludes dairy, and flexitarian, like you can have a non-veg and veg diet, both. So basically it is very good if it is lacto-vegetarian because you can have the balance of amino acids from milk and milk product being a complete protein, and plus curd, it can improve your gut microbiome also. Curd, yogurt, kefir. So these are the things which can help in the Plado diet to enhance the gut microbiota. So if we see the comparison between standard diet and Plado diet, the proportion of plant-based protein is 20 to 30% in standard diet, whereas LPD, it is more than 50%, 50 to 70%. But again, it is coming from some Western, studies. So if we see Indian standard diet, I can say that plant-based proteins, they can be 50%, 50 to 70%. Total protein per kg ideal body weight more than 0.8, usually 1.2 to 1.4, then again 0.6 to 0.8, in this LPD plant-based diet. Again, I can relate it to a normal Indian diet. Total protein intake per gram per day, 96 to 112. It is, but here it is 48 to 64. Protein density per 100 kilocalories, 4.4 to 5.1, whereas in Plado it is 2.2 to 2.9. And proportion of energy from protein, 16 to 19%, whereas in Plado is 8 to 11%, and it is true for most of us. And total plant-based protein gram per day, 24 to 34, whereas it is 24 to 45 in Plado. And animal-based protein, 68 to 83, whereas in Plado 14 to 32. So if we see this protein restriction Plado regime is individualized and is based on renal disease stage. So stage 1 to 2, protein intake 0.8 gram per kg per day. Plant-based protein more than approximately 70 to 80% of total protein. Potassium 3,500 milligrams per day. Avoid excess. Sunita has talked enough on this. Phosphorus intake, moderate restriction. It can be up to 1 milligram per day. Sodium to 2000 to 2300 milligrams per day. Calcium adequate, approximately 1000 milligrams per day, and monitoring every 6 to 12 months based on lab values and EGFR, urea, and electrolytes. Then stage 3, protein intake 0.6 to 0.8 grams per kg per day. Plant-based protein portion, approximately 80% of total protein. Potassium intake, moderate restriction is 2000 to 3000. Now here we are increasing the plant-based protein, but potassium we are reducing. It is again a challenge. Phosphorus intake restriction begins approximately 600 milligrams per day. And sodium intake again same. Calcium same. Monitoring 3 to 6 months based on lab reports as well as the nutrition profile. Then stage 4, Plado regime is protein intake 0.6 grams per kg per day. Plant-based protein portion approximately 90% of total protein. And potassium intake, careful selection. Maybe potassium leaching required and low potassium foods. Here, one point I would like to say is that, as Sunita also pointed out, high, medium, low. So I never give it to my patients because they become paranoid. Because, for example, nimbu hai, that is high in potassium, but we are not going to give 100 grams of lemon to a patient. A lemon a weight is only 10 grams, and if you give like 5 grams or like 2.5 grams and you tell him to squeeze in his dal or vegetable, is surely going to increase the bioavailability of iron, not enhancing much of the potassium content. So they become paranoid when they see the lists like, high potassium, medium potassium, low potassium. So the portion control, the portion size is very important while telling the patient that it is high in potassium or low in potassium. Anything which is low in potassium, if the portion is more, definitely it will become high in potassium. So phosphorus intake is again 400 to 500 milligrams per day. Sodium less than 2000, calcium 1000 to 1200. Supplementation might be required, and monitoring is required 1 to 3 months, every 1 to 3 months. And dialysis, protein intake is a little liberal because, the patient is on dialysis. It can be liberal, might be liberal depending upon the lab reports, 1 to 1.2 grams per kg per day. Approximately 50 to 60% of the total protein coming from plant-based sources. And again, potassium, we can revert back to 3,500 milligram per day. Too. Phosphorus, revert back to 1 grams or 800 milligram to 1 gram per day. Sodium, 2000 to 3000. Calcium, increased need 1200 to 1500, and more frequent monitoring weekly to monthly basis. So basically, the nutrient composition of a Plado diet is energy 30 to 35 kilocalories per kg per day to prevent protein energy wasting and maintain the nitrogen balance, and protein 0.6 to 0.8 grams per kg per day, out of which more than equivalent to 50% of plant sources, legumes, soy, whole grains, and grains which are have a good amino acid profile, nuts and seeds. Carbohydrates 50 to 60% of total energy, emphasis on complex carbohydrates. Now here, of course, when we are talking about the potassium thing and the carbohydrate, and we can always choose some carb forms like semolina or vermicelli, because they will be lower in phosphorus content as well as potassium content. And one more thing, if we are talking about the dairy also, like if we choose paneer or cheese, that cottage cheese, instead of milk, so we one thing is that we are reducing the volume, because there is a volume constraint in CKD patient. Instead of like 200 ml of milk, if it gives 6.6 grams of protein, so approximately 35 grams of paneer will also give the same, but then the lower volume and maybe lower phosphorus content. So these small things we can take care of in such diets. Fat 25 to 35% of total energy, focus on unsaturated fats. Dietary fiber 25 to 38, sodium of course less than 2 grams, phosphorus 800 to 1000 milligrams, potassium is always individualized, and the lab values have to be seen, as Sunita already pointed out, that they can the fasting samples and the way the sample has been taken, it really matters. Other micronutrients like B12 supplementation may be required, and monitoring iron, vitamin D, calcium status is very important, extremely important. So it represents a paradigm shift in CKD dietary therapy, combines moderate protein restriction with plant-dominant nutrients, improves metabolic and cardiovascular outcome. These are the promises, supports gut microbiome health, and may delay CKD progression and dialysis initiation. And it offers a promising, patient-centered, and sustainable approach to CKD management. Thank you.
Thank you, Nancy. Very well delivered. Actually summarizes everything so beautifully. And I love those points, take home messages.
Thank
Do
you.
not leach, and very well. And using hunkered also definitely helps. So your messages were loud and clear. Open to the house for questions, or maybe
Yeah.
we'll take them together, Shilpa. What's the plan? Yeah.
Yeah. So the questions should wait, or should we ask the questions, or anybody can ask? Anybody can
Uh,
ask any question. Are we short of the time, Shilpa?
Nancy, yeah.
I mean, we have a little bit
Both
time,
there in
but
the, yeah, I think the next session is question answers only. So both
yeah.
Nancy and yeah, Sunita are there. Also, they can join the group.
Yeah.
Yeah, and
But
the
it was very
panelists. They're
nice,
part
both
of the
of them.
panel.
Yeah, but it was excellent. And what do you say, Anita ma'am? Excellent
Yeah,
from both
absolutely.
of
Very
them.
well.
Yeah.
Absolutely to the point. Very clear messages and a lot of take-home messages. Congratulations,
So
Nancy.
just one question, Nancy. Are you recommending keto analogs? Are the doctors are also recommending keto analogs with this Plado diet?
Not really. I have not got any case as of now. And secondly, Plado diets, as I already said, that when they include milk and milk products, the things are not so difficult. So
Yeah.
if when they were, if you say Plado diet, vegan diet, I've not got any case. But yes, the normal low protein diet in which we were vibing for 50% high biological value, 50% and more than 50%, and the cases come like this, and they can be catered to with
Right. Right. Thank you. Thank you.
So thank you, Sunita, and thank you, Nancy. I mean, you have been like wonderful while sharing the practical insights And especially while you were talking about, I would appreciate Sunita for this, that adhering to the necessary dietary restrictions is only which is required for the CKD patient. It is not that everything, whatever has been quoted, is meant for all each and every patient. And Nancy, what you shared, like your perspective, that is a complex, I mean, science, and you've shared a very good comparison also between the regular standard diet and the Plado diet, which all of us had been following. And that clear perspective of following those clinical practice, that means that gives a kind of a roadmap for the patients also, that how they need to go about it. So, I mean, you people were excellent, and you made the day for the webinar. And
Excellent.
delegates, yes.
Thank you.
So,
Thank
Very, very
you.
clear, very clear messages.
Thank you,
so
Delhi chapter and Shilpa, for this opportunity. Thank you.
thank you so much for coming over here. And
Yes, Shilpa, thank you for organizing, and thanks to Azura, of course. And you always organize so very well every event.
it's with all of you.
Every.
Yeah. I mean, like, it's with all of you who have been present over here. So we move to another interesting session, and I would like our speakers also to stay back for it. And it is going to be interesting if all of us are being here, if, I mean, feasible with your time and all. So this is going to be a panel discussion, but a little with a twist. Okay. And it is whatever we are learning scientifically through your presentations, we have a little more real world applications. And it is pleasure to introduce our session chairperson and moderator, Ms. Zamrood Patel. Zamrood, you are here?
Yeah, good evening, all. I'm here.
Yeah, good
Hi,
evening.
Zamrood.
Yeah,
Hi,
hi.
Samruth.
I
So, I mean, it's pleasure to have you, Zamrood, over here. I mean, I've been following with you regularly to have for the webinar. So it's really wonderful to have you. And Zamrood is HOD and the Chief Dietitians at Clean Girls Hospital, Mumbai. And we know that she's our going to lead the distinguished panel discussion. Uh, should I introduce the panelists,
yeah,
Zamrood, or you?
please do the honors.
Okay. Okay. So we have our panelists. Just a minute, please. I think somebody has. Yeah, thank you. So I'll introduce the panelists. Our first panelist is our Deepti Kharuja, and she is Chief Clinical Nutrition with Fortis Memorial Hospital, Gurugram. Our second panelist is Ms. Ruchika Jain. She's Chief Dietitian with Fortis Hospital, Vasantpur, New Delhi. And third panelist is Ms. Prati Jain. She's Senior Manager HOD with Nutrition and Dietetics at Max Vishali, New Delhi. And our last panelist is Ms. Suhani Seth. She's HOD Dietetics at Yatharth Super Speciality Hospital, Noida. So over to
Thank you
Zamrood.
for having us here, ma'am. Thank you.
You're all welcome. And over to Zamrood. I mean, I would know that you can now navigate the things into I mean, whatever the kidney health nuances has been there. So you're going to lead it. Over to
Thank
you.
you so much, Shilpa, for having me there and making me do this. In fact, this is something that we do day in and day out. And I was just prior to this, I was in another session where actually we were discussing that, how patients sometimes don't understand what we say, and, they get carried away with something else. So probably I miss Sunita's talks. I have to apologize for that, but I know she must have done a fantastic job on road, which was always there. But I could hear Nancy, and she was talking of Plado diets. And today's topic that is given to us. So we are just going to be in the real world, to be very honest, because we are going to be talking about translating the theory into practice, right? So I can do my slide share. And
Yes, you can share it.
you can see the slides.
Yeah.
Yes, ma'am, yeah.
So
Yes,
basically,
perfect.
yeah, thank you. So basically, when I was making this presentation, and we were talking and we were discussing among the other of my colleagues who are there, I was just thinking that, how time has gone and how the importance of renal nutrition today, it's there on every doctor's tip of the tongue. But if it is a renal case, they will always want some nutritionist, some dietitian to be around to, help them out with their cases. So today, what I plan to do is to do this only, to have to do the cases. So I'm not going to get. I had made some basic slides on what are the important things that our kidney does. So I just want to make one important statement that I always do. Such a small organ, but such an intelligent organ. It excretes the waste products. It filters the fluid, maintains the chemical composition of the body fluids, but it also secretes something. It produces erythropoietin, renin, and activates vitamin D. So probably these are the reasons why this organ is needs so much of nutritional care. So probably the main thing that it does is excretion of waste products that those waste products are generated definitely from the protein metabolism. And as the kidney disease progresses, usually these waste products start accumulating in your system. And probably I have been seeing a lot of diabetic nephropathy cases, and these are the people who present with massive proteinuria. That means there is a challenge that we have where we have to give them only 20.6 to zero point 0.8 grams of protein, and with huge proteinurias, what do you do? So actually, we are going to be discussing all this in our cases. But one thing that we need to understand that each patient is different. Each patient needs a different type of a dietary modification. One size would not fit to all. So having said that, these are the classic things that we see. You see retention of waste products, retention of water and salt, and it manifests that patient's nutritional status gets compromised. Why? Because the dietary modifications that we give, and all this leads to protein energy wasting. And probably this is something that as a nutritionist, if I am seeing patients from the beginning, I need to control, because if I am not able to control them, that means I am not able to give them the right nutrition. So, having said that, you have to understand the importance of assessment. Nutritional assessment is a very important part when we are talking about management of CKD, or for that matter, any kidney patient. So that's very important for us. And how do you assess? There are various tools available. Probably why we are worried about this is because morbidity and mortality are related to malnutrition, and that is why you need to feed your patient well before they get any further complications because of the nutritional management that we do. So having said that, I come to my first case. This is a 45-year-old male, diabetic hypertensive for 15 years, having proteinuria, low hemoglobin, of course, because anemia is a part of this disease. His recent creatinine is 4, uric acid is 7. He is a non-vegetarian. He has a slightly high cholesterol and potassium also. If I have to see his height and weight, his height is 170 centimeter and weight is about 65 kilos. And he's feeling extremely weak. He's lost around 4 5 kgs of weight, and this is weight. This is not edema that he has lost. So, having giving you the same scenario, I would request Dipti. Dipti, how would you do the assessment for this patient? What do you think is important when you have to do the assessment, and how would you actually guide this patient?
So, thank you so much, IAP and Delhi chapter, Shilpa ma'am, for having me over here. I hope I'm audible.
Yes.
Okay. And thank you for this question, Amrud ma'am. If I have to do a nutritional assessment, so first we need to understand that nutritional assessment is very, very important and the first step in the nutrition care process. And why it is important is if assessment is done correctly, I think then we can plan the right practical applications for the patients and then get the follow-up done and monitor them on regular basis. And then when actually reassess the patient to see how impact the assessment or the intervention has been. So I think it is a very, very important role as a nutritionist. The assessment has to be absolutely correct. So when I say nutritional assessment, there are a lot of factors which have to be taken into consideration. The basic parameter that we work is ABCD method, where A stands for your anthropometric measure. So in this case, I would say BMI, although it was absolutely fine, somewhere around 22.5, keeping the present body weight of 65. But however, as our earlier speakers, Sunita ma'am has suggested that, what we have and the researchers have shown that if we have a slight obese, BMI of 24, which prior to weight loss, the patient would have been with the BMI of 24.2 or 24.3. If we consider that as 70 kgs, if he has not lost, I think that would have a better impact on the patient, recovery and progression process. So getting into slightly on a BMI of 23 to 25 is something that we would recommend. So anthropometry becomes very, very important. And here one more important aspect that we need to take is the dry weight of the patient, so that the ascites or the edema part is taken care. So as in the anthropometry, we should always try to take the dry weight. If the patient is not on dialysis, we have various tools to assess the calculations by which we can actually, by the percentage, we can calculate the approximate dry weight of the patient. The next B stands for your biochemical markers, wherein again in this patient, I would say very, very important to understand what were the creat levels. So with the creat of 4, the patient's CKD stage has to be assessed from the GFR, which is an easiest method that we all know. And also along with that, we need to take care that, the uric acid, the blood sugars levels, and the cholesterols, they are all have to be in sync when we are going for the assessment and the intervention for this patient. As with our earlier speakers, we have understood that kidney has an impact on all these functions, and then we have to take care of that. The next is the clinical part, wherein edema, ascites, and what is the nitrogen appearance, urea nitrogen appearance, we need to assess, and accordingly we need to plan that. And here edema, ascites, and proteinuria would also be important to be taken care of. The last but not the least, the D stands for your dietary interventions or dietary recalls or dietary diaries that we have to say. So again, I would say if we are looking at the dietary 24-hour dietary recall, the very commonest method that we all use in our hospital setups. But if the intake is less, we need to dive deeper with the patient by, from the patient and the family, that for how long the intake has been on low. What was an average intake for, say, last 1 week, I would say, to understand on an average 3 days out of the whole week, to understand whether it was only yesterday the intake was low or it was generally on the lower side, and then plan out to the calorie protein targets for this patient. So in this patient, in the overall scenario, I would say something commonly used tools that we go ahead is the subjective global assessment tool that we all use in our setups. But there is a tool which is malnutrition inflammation score, which is again a very good tool, and which talks about the dry weight, also taken into any weight loss changes for these specifically dialysis patients, and whether the patients on dialysis more than 4 years or less than 4 years, along with the physical examination and the biochemical markers. So in this patient, I would say, along with the assessment, we have to come up with the nutritional diagnosis, because from the assessment, we would be able to come out to a problem area for the patient, and then to develop how we can intervene in that problem area and we can improve the intervention for this patient. Also, in this case, I would say very, very important to assess, where it was mentioned that the uric acid was 7 and the patients was taking non-veg almost daily. So while we had 50% high biological value proteins, even though if we are restricting the proteins to 0.6 or 0.7 gram per kg ideal body weight, then we need to take additionally 10 grams for the proteinuria loss, because proteinuria we saw in the labs were 10 gram of proteinuria. So we need to additionally add 10 grams, and of that total protein, we need to give them at least 50% coming from the high biological value protein. So in this patient, we need to really counsel and make them understand to restrict the non-veg sources, probably twice a week or thrice a week in small quantities. Egg whites are the safest options, which the patient can have it, even including the uric acid into consideration. So diabetes management, again, the calorie would be somewhere around 30 to minimum is 30. We can go up to 35 depending on the keeping the weight loss into consideration. And then we can, go for low sodium 2-gram salt diet to prevent any edema and all.
Very well said, Dipti. Actually, very honestly speaking, you've covered all the points. Only one thing that most of the time many people are missing in the routine practice is the proteinuria. So basically, you rightly pointed out that if the proteinuria is beyond the nephrotic range proteinuria, you need to add that many grams of high biological value proteins, and egg whites are the safest bet here. Because for a non-vegetarian patient, if we prescribe a vegetarian diet, probably they will not adhere. And even if you see the Plato diet definition, Plato diet just says that 50% of the protein should come from proteins, plant based. Actually, you can add other dairy or egg whites in their diets. So I think basic understanding that what Dipti
So,
has
ma'am,
given to
one
us
thing I would want to add, most commonly the myth in over here that we normally see in our OPD also is
yeah.
patients come to us saying, "Dale ban kar do, Rajma has a high
Correct.
potassium." So what Sunita ma'am, Nancy ma'am has already talked about, it is the grammage and the total
Correct.
potassium during the day. So if we go with the IFCT book
Hmm.
2017, lot of foods have been added what we used to counsel 15-20 years back. So I think it is important to educate the patient and family to make them understand how to calculate the total potassium rather than just restricting everything.
Yes. So I think you rightly made the point that nutrition education is important for all. Nutrition literacy today has to be given to everybody. That's very important, Dipti. So now moving ahead to my second case. This is a 50-year-old female who's hypertensive for 15 years. She has a creat of about 3.2. Sodium is fine. Potassium is on the higher side. Her CRP is 15. Her BP remains on the higher side. If I have to see her anthropometry, her height is 160 centimeters and weight is 45. She is losing weight, and in the last 2 months, she has lost about 10 kilos of weight. She is a Gen vegetarian patient who's using skim cow milk, and I can show you her actual recall. Her recall, if you see, she has a cup of tea with half paratha. So paratha means something like a thepla that they make, or a paratha. Lunch is around 1 to 2 fulkas with little dal, vegetable, curd. But because she's not getting food taste in the mouth, she's eating little papad. Evening, she avoids to take any snacks, so or she's not hungry probably. So little farsan she munches on, and to get that little taste to her mouth. Evening, she may take a fruit. Dinner is half the quantity of what she eats as lunch. So now, with this type of a patient, I would request Ruchika, what could be your dietary assessment and what could be your dietary prescription? Ruchika, you're there? Hello?
Let me call. She was there. I mean,
Her mic is off actually.
Yeah, she is muted actually.
Yeah, she's muted.
She's
Ruchika,
talking.
can you unmute yourself?
Ruchika, you are muted.
It is done?
No, I don't think so.
She's joining.
Okay, so basically, just speaking on the case, basically here again, this patient does not have diabetes. Okay, 50% of the patients with chronic kidney today have diabetes. Fortunately, this patient is not a diabetic, but she is hypertensive, and she is a person who does not eat well. So probably, we really need to pay attention to her nutrition. That's very important. So when we are doing this case discussion, these are actual real time cases, and whatever the information first hand we've got from the patient, we are presenting over here. So has Ruchika joined us, or do I? Hello.
She's there. She said
She's
that she
not.
is.
She's not able to unmute. What is it?
Yeah,
Or
but still she is muted.
Okay, so anybody else would like to discuss this part?
According to me, I think this patient is malnourished because as per the weight and height, the weight is very less, and also the patient is losing weight. So 10 kg weight she has lost in 2 months. Also, the potassium is high, but still the patient is eating the papad, and even the patient is a CKD patient having salted food like that papad, and also potassium, because of the potassium they are eating the fruits also.
Yes.
So if the potassium is high above 5,
Yes.
ideally we should be restricting the fruits. And because the patient is CKD, so we should be restricting the packed, preserved, processed foods like papads and all. Like farsan also the patient is eating. So farsans also have, because I am also Jain, so I know they have more salt in the food. And if we talk about the good quality protein, and if we take the dietary recall of this patient, so only one katori dal the patient is consuming. So the protein requirement will not be going to fulfill. So only one katori dal is there as a source of protein, and 1 cup curd. That's all. So
Correct.
it is very lacking in Ruchika is already there, ma'am. I think she can talk.
Okay. Thank you. Thank you.
Ruchika, unmute yourself. Ruchika, unmute yourself.
I think
Yeah,
Yeah.
you did that now.
Yeah, am I audible now, ma'am?
yes, please.
Yes.
Yeah, you can start, Ruchika.
Yeah, so I think Prachi has already given an overview about this particular case, ma'am.
Yeah.
And as very rightly said that she's a 50 years old female with hypertension for almost 15 years. But as her report says, as far as the creatinine level is concerned, that is 3.2. So maybe we can calculate the eGFR, and that would be almost around with the help of Cochrane formula. If we'll calculate, so would be almost around 19.9. So the
Correct.
CKD stage would be around CKD stage 4. So that we have already emphasized, the previous speakers have already emphasized that CKD is a progressive disorder, and as the patient progresses with the disease, the malnutrition status might further worsen. So that could be one of the reasons of the poor nutrition status of the patient, which is clearly shown by the height and weight. If we calculate the BMI of the patient, it would be almost around 17.5. So that again indicates that the patient is in the underweight range. The second thing which we could make out with the weight loss of the patient. So it is very important for us to understand that the patient is only already losing weight as far as her 1 day dietary intake, which is clearly shown in the case that her dietary intake is on a lower side. So firstly, before telling about the dietary assessment, I would also emphasize that we need to discuss in detail with the patient and the relative the usual intake of the patient. That is, what she takes on a daily basis, what is the trend of her diet, what is the trend of her weight loss, why is the intake poor on a particular day, is it a particular day or this has been the usual routine, maybe because of the nausea and vomiting which she has because of the uremia, because she's already at CKD stage 4. So there is, because of non dialyzed situation, she might have uremia, and because of that uremia might have nausea, vomiting, and such complaints, which further suppresses the appetite. So we need to know with the patient that is her appetite low or she's having vomiting and nausea and such other issues. So that is one thing which is to be done. The other reason behind her malnutrition could be because the progression which is already there. Her CRP is also on the higher side, which indicates that there is a inflammatory changes also is going inside the body because of the other comorbidities there, because she is already a hypertensive for quite a long time. So the other comorbidity with the raised CRP level, with the progressive disorder, with the lower poor intake, all these things contribute again to the malnutrition and to protein energy wasting. Although there has been no other biochemical parameter as in albumin or pre-albumin or transferrin, all these things can also be used as an indicator for her nutritional status, although it is not there in the particular case. But still, for the next follow-up, we can always ask the patient to get these things done. We can always keep a follow-up as far as her weight is concerned. We can use hand grip strength for for monitoring the protein energy wasting, and then we can do it with the regular follow-ups as well, and maintain a record. And which was very rightly and well said by Sunita ma'am also initially, that there is a lot of dietary restriction. Not necessarily that she must have undergone any dietary assessment before or any nutritional counseling before. So it is very important for us to assess the knowledge also of the patient by taking a detailed discussion with the patient, that what's her knowledge about the disease, what's her attitude towards the disease, and what is she's actually practicing, the way we used to do KP earlier. So that also becomes a very important thing, because at times patients also over restrict themselves without realizing. With the fear of progression of disease, they over restrict their diet, and because of that they ultimately land up to further malnutrition. So it is very important for us to know the knowledge status as well as their attitude towards the disease, and finally guiding them right, that protein is important for them, right calorie is very important for them. Because as far as her intake is concerned, we can also see that her total calories also she's unable to meet, because as per the normal recommendation says that almost around 30 to 35 kilocalories at least we should target, because she's already a malnourished patient. So as such, looking at her intake and after taking her regular intake, we might know that on a daily basis she might not be taking sufficient calories, or she might not be taking sufficient protein, which is clearly cut seen in her intake as well. So we can emphasize on a good protein as well as a good calorie intake. The other one more point which I would want to pinpoint is looking at her salt intake, because probably because of the less taste in the food, she's also increasing indirectly the sodium intake, because she's consuming a little papad maybe to improve the taste, or little farsan because maybe she's not hungry at that time. But that indirectly adds to the sodium content of the meal, which could be seen with her BP levels also, which are on a higher side. So it is important for us to guide her in that sense, that her sodium intake should also be in a controlled way, and what all healthy things she can include as in between her meals. So giving her, discussing her as per her preference, a good diet, a high calorie diet, a protein rich diet with many options for a good snacking options included in between, as per her preference and choice, to be taken care of. Some good tips which might help her for nausea, vomiting, and lack of appetite: adding a little spices to her diet. Maybe she's not adding adequate spices for adding the taste, because at times the people are also taking boiled food out of consciousness. They take boiled food, which reduces the palatability. So taking a palatable meal is also important, which we would be able to judge after taking a proper recall her attitude and practices towards the diet which she's following. So accordingly guiding her for every meal, in between snacking, a high calorie, a high protein, a low salt, and definitely a potassium restricted, in the sense that she should know that what all potassium sources she can include, what all salt sources she can include, not going for the salt substitutes as already discussed by our other speakers as well. So these all things are very, very important as far as my point of view is concerned for this particular case.
Very beautifully said. Only I would like to only highlight one thing is that many times when you see the biochemical profile. Now, if you see over here, the creatine is just 3.2 with a weight of 45, and beautifully put by Ruchika that this is stage 4 CKD. So, you have to understand and interpret the reports properly, because the interpretation for creatinine goes this person has a low muscle mass and a low intake of proteins,
Definitely.
and that is why the serum creatinine is on the lower side, and probably she is still at the advanced stage where her appetite is getting suppressed. This is beautifully explained. So probably, how do you interpret the reports, that is also very important for us. Probably because the person is not eating well, the person is thinking of taking something, and just for just filling the stomach. So now coming to our third case, This is a 65-year-old diabetic hypertensive female who has severe ischemic heart disease, has peripheral vascular disease, and is presenting with again a weight loss in the last 6 months, has refusal to eat, reduced appetite, and there is swelling and redness of the right toe. This patient is an end-stage kidney disease patient on maintenance hemodialysis from the last 7 years, and she takes this treatment in a center close to her house. She has a history of recurrent pancreatitis. She has got this twice in the past. Now the family is informing that there is inability of her to eat. She has severe epigastric pain and that she has a redness of that right toe. She has occasionally loose motions and nausea. The family also mentions that she becomes drowsy and that may probably the hypoglycemia throughout the day, and this worsens during the hemodialysis sessions, and they are now providing her sugar sachets because she is not eating. If you see her investigations over here again, her hemoglobin is 8.2, albumin is low, creat is low, her phosphorus is low, cholesterol is low. He is just weighing 38 kilos with a height of 160 centimeters. So, Prachi, I again come to you. How would you assess this case and how would you guide further for the nutritional management?
Yeah. So very interesting case, ma'am. This is a senior citizen. Basically, she is having all possible comorbidities: diabetic, hypertension, heart disease. Even she have that pancreatitis, recurrent pancreatitis. And the one most important thing is that she is having nausea and low appetite along with the food refusal. So what I feel, she is severely malnourished. If we see the height and weight, and according to that, if we will calculate the BMI, it will be near about 14.8 to 15 kg per meter square. So she is severely malnourished, and her albumin levels are severely low. Because she is not eating food, nausea is there. It can be because of the antibiotics, chronic condition of the CKD, as it is a progressing disease. She is on end stage renal disease, low appetite, epigastric pain. So basically, she is hypoglycemic because she is not eating anything. So this is the overview of what I am getting about this case study, and that's why she feels drowsy. And in between the dialysis session, she needs to get and have sugar sachets to get some energy. And her condition get worsened during the dialysis because she is on hypocaloric and hypoproteinemic diet. So according to me, the assessment would be very, very important. And that assessment is because nutritional assessment is the first and the basic and the foremost tool to understand the nutritional diagnosis. The first thing is I want to know why this patient have the food refusal. Maybe she is not liking the taste, she has low appetite, her morale was down because from past 7 years she is on dialysis. Right. And maybe psychologically also because she is an elderly woman, so I feel that she have some psychologically low level of understanding and acceptance, maybe that she needs to eat food to get recovered. So maybe she is not like fighting with this, and she have less hopes. So according to me, if we will do the nutritional assessment, then after that, if we come to the nutritional diagnosis, she needs a high calorie, high protein diet. But again, if we will plan on paper and in a diet plan, high calorie, high protein, it will not work in this case because she has a refusal also along with a low appetite. So according to me, what we can do is we can give a short and frequent meal along with her preferences, food options, and food habits. But along with that, maybe we need to add some oral nutritional supplements to her, because the person who is not eating and she needs a sugar sachets to get some energy, if we will set the target calories and proteins, even then in 1 week also we would not be able to counsel and achieve the target calories and protein goals. So some calories and proteins maybe we will be adding from the diet, maybe soft diet or the convenience diet, which she can have the preference diet according to the food habits, along with some nutritional supplements. And as her albumin levels are less, so as Sunita ma'am also discussed that protein wasting, energy wasting, if patient have high protein energy wasting, they have higher chances of mortality. So we need to counsel for the protein supplements, the supplement, oral nutritional supplement which we are talking about, we need to add that in her diet. Along with that, I feel her that protein, she needs basically the family support also. She should be reaching and contacting with the dietitian, and frequent follow-ups are required so that she will be little positive. Along with that, I feel she also should take the sessions of a psychologist also, because I feel the where the food refusal comes, it triggers to me when patient didn't want to have the food, though the person can have. So there are maybe psychologically she is not fit also. So maybe psychological sessions and counseling therapies may also help her along with the nutritional counseling sessions. So according to me, high calorie, high protein, which will be like 30 to 35 kilocalorie per kg body weight will be the target. But slowly and gradually we need to fulfill the target, because in 1 week or 2 week, I don't think so we would be able to make her convince and make her eat. Otherwise, maybe we need to initiate for enteral nutrition if she will not be taking the oral nutrition and soft diet or a normal diet or a convenience diet accordingly. Then maybe we need to connect with the doctor to put and insert a RT along with the oral diet.
Absolutely, you hit it right. So basically, in this case, that was done. The diet was liberalized. Her dialysis was increased to 4 times a week, and she was given a challenge of ONS plus a tube was inserted. And in 2 months, she was started asking for food. So, sometimes as nutritionists, we understand and beautifully put by my colleague that you have to talk to the doctors. You have to understand and you have to tell them what probably we can do together. So, rightly put, you need the support of a counselor, you need the support of the family, and you need to plan and give good nutrition to this patient. So, many a times just writing it on paper does not help. On paper it is just one paper sheet that goes in the file to build the file up, but we do not work that way. We want the prescriptions to be actually followed by our patients. So very beautifully explained. So I go to the next case. This is a 22-year-old male, middle class family, non vegetarian Maharashtrian. Now, if you see his history, he was diagnosed with nephrotic syndrome and was on treatment. Okay, he was hypertensive. He suffered CVA 2 years back and has progressed to chronic kidney disease now. So if I have to show you this ahead, if I have to take you, his height is 160 centimeters, weight is 60.6, so BMI is fine, body weight is fine. His BP is also looking good. His recall is showing an intake of 1550 calories and 45 gram protein. Now, this is a young fellow, 22-year-old. So he goes to the gym, and when he goes to the gym, he eats pre-gym banana, and post-gym he eats potatoes and egg whites. He is college going, so there also during the breaks he eats fruits. His lunch in the college is roti sabji dal chawal, and dinner is rice dal, and at bedtime he has milk. So now I come to you, Suhana. What do you think, Suhani? Sorry, what do you think about this case, and how do you interpret this case? This is very
Uh, Ma'am, now this is a very classical case where a 22-year-old young adult
Hmm.
undergoes nephrotic syndrome for almost 4 years, and of course, hypertension also for about 4 years, and the patient suffers from CDA. So, we are very sure that the patient has uncontrolled hypertension for a prolonged period of time.
Hmm.
Unfortunately, with that tenure of nephrotic syndrome and hypertension, the patient has creatinine clearance has reduced down to less than 20 ml per minute, which is very clear that the patient has already landed up to CKD stage 4. So, with uncontrolled, despite of nephrotic syndrome being treated, but probably because of uncontrolled hypertension, the patient has landed up with this stage of CKD. And the major problem which comes with this advanced CKD, and that is CKD4, the inflammatory cytokines are not effectively cleared.
Emergency. Code white, accident and emergency.
Sorry, there was a code announcement. Sorry,
That's
yeah.
why we totally familiar to all these things. So the inflammatory cytokines are not effectively cleared, and their accumulation causes chronic systemic inflammation, oxidative stress, and specifically protein energy wasting in this patient. Ma'am, I request you to go back to the previous slide where the medications and the levels are mentioned. Now, this patient has a higher creatinine level of 4.8. The creatinine clearance is already 20.4. The rest of the report seems okay, but if we go down, the PTH level is high, which is 313, and the patient's urinary protein losses is also 3 plus. The patient is on certain medications. Ma'am, can I have that slide, please? So the patient is already taking I can't see it well. Is on Febutaz, which is an anti-gout and has been used to treat the high uric acid levels. The patient is on calcium channel blocker because it's been used for the antihypertensive treatment. Taking antacids, obviously to treat the acidity and intestinal issues. Patient has also been taking calcitriol and the beta blocker. Now, this is a very typical case where the nutrition management should basically focus on how we can reduce the CKD stage to go on further, to go down further. We try to stop the patient here and slow down the progression to CKD stage 5. Also, we need to manage the complications and alongside maintain the nutritional status of this patient. Now, if you see, the patient is taking about 1550 kilocalories, and this is a young adult. And if I have to see, the patient's calorie recommendation is about 30 to 35 kilocalories per kg body weight, which is about 2100 kilocalories a day. So this patient has already been deficit by about 600 calories. And this, if continues for a prolonged period of time, this patient will land up with something what we call as protein energy wasting. And once such situation arises, it is very difficult to treat malnutrition alongside the chronic kidney disease. So we need to incorporate some healthy fats and complex carbohydrates to meet the increased energy requirements. If I talk about the patient's protein intake, which is about 45 grams, and compare it to the patient's requirement, which is about 0.6 to 0.8 gram per kg body weight, it is more or less appropriate, but we can focus more onto high biological value proteins and a good quality plant-based proteins as well, so that all the proteins are well absorbed for this patient, and we can prevent the patient from undergoing muscle wasting. Now, very importantly, the patient is on the antihypertensive drugs. We need to ensure that we control onto the sodium intake of this patient, which should be at least less than 2 grams a day, so that we have the improved responsiveness of the antihypertensive drug this patient is taken, and primarily treat hypertension and prevent edema in this particular case. Also, in the advanced CKD stage, we know that the potassium excretion decreases. So this patient is taking potassium-rich sources pre and post workout, and is also consuming fruits during the breaks in the office hours. So it is no harm that the patient cannot take potassium. That is not the thing. But the patient potassium levels needs to be checked on a regular basis, so that we understand that whenever the potassium is going beyond a certain level, we need to counsel and tell this patient to consume the limited quantity of potassium through specific sources and cut down and make a change in his current routine. Another very important thing is the PTH level of this patient is already 313. So the patient is suffering from what we called as secondary hyperparathyroidism. So it is important that we control a situation which we call as CKD mineral bone disorder. And to do that, we will have to reduce the patient phosphorus intake to about 800 to 1000 mg per day. What is important is that we need to tell the patient the correct way of limiting phosphorus. Leaching or just eliminating all the protein sources or all the phosphorus rich sources doesn't help, but correct quantity, portion size, and the way of consuming will help this patient limit onto the phosphorus content. Also, this patient is taking calcitriol, which is okay, but the mineral density gets affected in the CKD advanced stages. So it is important to prevent a risk of vascular calcification. We should reduce the calcium to about 1200 mg per day, and we should use appropriate sources and balance out food intake with the supplement intake. So these two things should be balanced out. Now, if I have to understand that this particular patient, if not addressed at the right time, will progress to CKD stage 5 and will land up in a situation of dialysis. if protein energy wasting occurs in this patient, so dealing with dialysis will be a task, and the patient may not respond to dialysis because the patient is suffering from malnutrition. So we have to treat two things alongside, which will be CKD and protein energy wasting induced issues. So if I have to particularly sum up this case, the chronic inflammation may be a key factor which links the protein energy wasting with increased morbidity and mortality. So we have to identify and we have to manage inflammation along with the adequate nutritional support, which is essential to reduce the complication and improve the survival in this particular case. So this is what I wanted to talk about the management of this particular
Yeah,
case.
very beautifully summed up the whole thing. So basically, inflammation is also something that we really need to pay attention along with nutrition because they go hand in hand because of the protein energy wasting that is happening. So now I will move on to one case, which is a transplant case. Okay, this is a 60-year-old female who has a history of hypertension, chronic glomerulonephritis. She was on dialysis and has undergone transplant. But and these parameters that you see are just immediately post transplant. But before I go and speak about transplant, I would request Dipti that if you see such a patient pre-transplant, what would be your assessment? Because this person is going to be on dialysis and the patient is going to not be eating very well. So, what would be your suggestion pre-transplant for the screening and assessment of this case?
So, for this case, ma'am, the first and the foremost thing that we need to understand is when we are planning for the transplantation to be happening, we need to start referring the patient to a nutritionist, which in most of the Indian scenarios at present is not happening. Because if even the guideline says that 14 days, the first initial 14 days are very, very crucial and very, very important to build up the nutrition before the transplantation, being a liver transplant or a kidney transplant that we need to work on. So I think doing the assessing of the patient in the OPD basis becomes very, very important. A very tight control and follow up with the pre-transplant assessment has to be taken care. And in this case, I would specifically put, like you said, because of the dialysis, the patient intake might not be very good. So as Prachi discussed in her case, that enteral feeding, we can speak to the doctor, and very rightly said, multidisciplinary team has to be approached, and we have to work not just for the enteral feeding, but we can work out a catch-up feeds for these patients, where in our scenarios, we do is we allow the patient during the daytime to have the oral intake, and whatever the deficit is happening, we can plan the tube feedings, the cyclic feedings during the night time while the patient is sleeping to build up and that deficit part of it, so that the patient have the psychological feeling that they are having orally also. At the same time, we are not compromising on the nutrition. Definitely the blood sugars have to be controlled for these patients, because if the blood sugars are not controlled, the impact on the transplantation circumstances would be there. And definitely, since the uric acid, definitely even the post-transplant, we can see it was 7.7. So we need to assess their intake in terms of the non-vegetarian foods, get them back to the right approach. And definitely the most important is 50% coming from the high biological value protein that we have discussed, because most of the time the myths is that dairy and dairy products have phosphorus, which Dr. Nancy and Sunita ma'am have already taken it. So we need to give them at least some minimum amount of, half liter of milk and milk products in any form, so that you're being a vegetarian, most of them, Indian population being vegetarian, we can take on the 50% coming from the high biological value protein, at least in the vegetarian sources. So I think it is most important as a nutritionist that we need to work on the pre-assessment of the patient, and the beautifully we have 14 days to build up those patients. That's the most important key takeaway that I would say for this patient.
Yes, Dipti, beautifully summarized. Now I come to Ruchika. Ruchika, this patient is with you immediately post transplant. How would you take care of this patient and what would you plan for this patient? Ruchika is there with us?
Yes, she's there. I think she's again muted.
So I think Prachi, if you can take this, and next by the time she comes, we can give her the next question.
Sure, ma'am. So, in a operative case, if we talk about this patient, like we need to take, as the patient is on suppressants, and they have chances to get the infection because of the low immunity, and graft rejections can happen. So, they need to be very cautious about the food what they are eating, and because the healthy kidneys are that surgically introduced, so the restrictions will be less now, and a post transplant now the patient needs to build up the stores, so diet will be obviously high calorie, high protein, and fluid restrictions. Now there will be no fluid restrictions, earlier there will be the fluid restrictions, so the healthy kidneys are will be there. So the person should eat high calorie, high protein diet, taking care of the fresh homemade cooked food, so that there will be less chances of infection. Even if the patient want to have salads and all, everything homemade, instantly given. Matlab, if we will not give the chances to get the
Very good.
exposure, then it will be fine. There will be generally in the hospital settings, we don't give cut fruits and we don't give salads, because there will be the time gap while cutting and while actually serving to the patient. So, but at home we can counsel the patient that you can instantly cut and peeled, and sanitation and hygiene should be maintained, so there would be less chances of infection, because infection can be from the food, it can be bacterial, viral, and it can be any type of infection, because they are already on immunosuppressants, but they need to build up the stores. So first 2 months will be very very crucial in a peri-operative case. And if we will see the reports also, here albumin and total proteins are on a borderline, so we need to build, and that is again 1.2 to 1.5 gram per kg body weight protein should be administered with the diet. And because this time the patient will be better on the diet, oral intake is improved generally after the post kidney transplantation, because the restrictions will be less. So patient generally is willing to eat the food, variety will be more as compared to the pre kidney transplant condition. Restrictions will be less, patient is morally boosted up, so patient's appetite will be quite good, and patient is willing to eat. So we need to be taking care of that. Patient should not eat all the unhealthy stuffs,
Correct.
like
Now the
fried
patient is with
foods.
you in the hospital, so that part will not come, because you will really take good care of your patient and not
Exactly.
do anything. So
Exactly. So
yeah.
but yeah, so but while giving the counseling, because after maybe 1 week or 10 days you will discharge the patient, and at home also they need to take care of, because in
I'm
a
coming to
hospital.
that to Ruchika, that when this patient is going home, what counseling would she do for the patient? Ruchika is there now with us now? She's
Yeah, yeah,
unmuted.
ma'am.
Yeah, please tell me.
Ma'am, in that case, I think both the earlier panelists have already emphasized the importance of nutrition, which is like an undergoing process for any transplant patient. But definitely, one very, very important thing, fluid becomes a very important part. Then we need to focus on a weight maintenance part also. Then apart from that, the hygiene part is also to be taken care once the patient goes home, so that he doesn't catch any kind of infection. For that, the dietitian would already be counseling and reinsuring once the patient goes to home before discharge. So that is something which is to be taken care of. And apart from that, as Prachi was about to say that at times the patient thinks that now I can eat everything and everything is allowed, so there should not be an overindulgence towards the food. Definitely slow and steady he has to go. And at times, because the patient is on steroids, so sugar monitoring also becomes important, weight maintenance is to be taken care of, steroid and apart from that, the fluid intake, which is very very important post transplant. The patient has to really maintain good lot of fluid and protect himself from various infections, so that again becomes a very important part. And then do come back for the follow up, so that the doctors and the entire team are able to judge their status level wise.
Yeah, very true.
Add
Very
that the patient's protein requirement raises up post transplant. So
yeah.
for the graft acceptance, because the patient is already on the immunosuppressant, and obviously we want the kidney to get accepted by the body, we need to ensure that patient is taking good enough quality of protein, about 1.2 grams per kg of body weight, for at least a period of time, and to ensure that the graft is accepted. And once the things goes normalized, we can always have a patient for a follow up, and we can bring down the protein to a normal requirement after that.
Yeah, sure, sure. Now I come to Suhani. Now this patient was taken very beautifully care in the pre, peri, and at discharge. But on coming on for a follow up, and after 3 months of coming of after 3 months of transplant, this person has come with a weight of 60 kilos and a random sugar of 200. Now, Suhani, how would these people have done their job, but the patient has not followed? Then how do we handle this?
See, we need to understand that post transplant, where the requirement after discharge was suggested that you have to eat better proteins and have to be improved, have to be on the better quality of calories, and everything has been taken care of. We've counseled for a high calorie, high protein diet. But if the patient is still coming with a weight loss, firstly
Weight
we need
gain,
to
not
assess.
loss. Weight gain.
Ma'am, the patient you said that has come down to 60 kgs, no?
No, no, no. 160 is the height. Now the weight is 80 kilos.
Acha, so the patient has come up with the weight gain.
Yeah,
So there might be chances that once you, as very well said by Prachi, the sab kuch khao concept begins post transplant.
very
So we
true.
need to understand that what exactly the patient is consuming, because after, pre transplant, where the patient was imposed with lot many restrictions, post transplant they think that we are now absolutely fit, we are like a normal individual, and we can consume whatever we want to. So a lot of eating from outside starts, a lot of fried fatty food intake starts. And when we
Okay.
talk counsel them for a high calorie and high protein diet, instead of focusing of ghar ka khana and protein predominant diet, they focus more on to a very easy going and a very happy going diet, which includes fried foods and everything which tempts all of us. So usually these patients land up with weight gain in an unacceptable way, and alongside their cholesterol levels get affected, and if this has not been controlled in a proper way, obviously the blood sugars will also get affected. So we need to first understand that where the patient has gone wrong. We need to take the 24-hour recall of this patient. We need to understand that where all the lapses are happening, and then focus more onto the proteins, the fibers, and good quality home based diet for these patients, so that we can control onto the unrequired weight, and which is increasing for no reason, and obviously the blood sugar levels.
Wow, beautifully summarized by all the panelists. But we need to make our patients understand this part, because what is happening with them is that the vicious cycle should not begin again. Because if the vicious cycle begins again, then the same problems will start, and eventually we'll reach a stage where again they will be looking out for a second transplant. So I think, thank you, my
Ma'am,
panelists. We
the
have,
most important, sorry, so
yeah,
one thing that I would like to highlight over here, the most important part is the post follow up, 1 month, 3 months
yes,
post transplant, and after that, I think every 6 monthly, these
yes,
patient needs to be followed up at least yearly at least, because normally what we have seen the trend is post everything absolutely fine, they don't turn up for the follow up. So they are doing the medical follow ups, but nutritional follow-ups is something that is major lacking in these
yes, yes.
patients.
I totally agree with you. And nutritionist follow up is totally lacking. They would definitely come to the hospital do the other part,
And
but
the doctor
they
follow up.
think now they are normal. So अभी तो normal खाना है ना, सब कुछ खा लो, थोड़ा कम खा लो. So
And physical
thank you, my
activity. Yeah.
panelists. Yeah. And
Thank
thank you, Shilpa and Anita, for having us and giving us this opportunity to share these cases. Thank you.
I mean, thank you, Zamrood. You were wonderful. I mean, the kind of masterful navigation you were giving to your panelist, we could really see and enjoyed the panel discussion also. I mean, it was truly exceptional the way you have been handling it. And I think without the normal panel discussion and the case-based panel discussion, like it is been more focused and easy to understand for the delegates also to what to do in certain kind of situation. And moving beyond theory is, I think, what is really required right now, real case-based discussions. That actually happens because we are all working into different hospitals and units, so have a different way to handle also, though we all doing good work, but
Yes.
sometimes it's a time, even if we can learn from each other, the better way to, assess a case or proceed with the case. So it is going to help out ultimately the patients. So thank you so much. Thank you all the panelists. Deepti, you were wonderful. Prachi, Sohani, and Ruchika, you all did a great job. You have been working already into experts into your hospitals. So this kind of multifaceted complexity is how you have handled. That's been really appreciable. So I would over to Binu for vote of thanks now. So it was a great panel discussion. Thank you, everyone.
Thank you.
Thank you, everyone. So, as we have already come to the end of this insightful webinar organized in observance of the World Kidney Day, so it's my privilege to deliver the vote of thanks. First and foremost, I would like to express our sincere gratitude to all the speakers and the panelists for sharing their valuable knowledge and expertise on the kidney health. And it was a need of the hour, like the Miss Jamrood has already taken like moderated the panel discussion related with the real cases evidence, and that is the need of the hour, basically, because nowadays practical and theoretical is totally two different scenarios. So when we are dealing with the practical things, yes, there are many of the challenges which come across, and how to go for those challenges, how to sort out for those challenges, that is the major thing. So I would also like to thank the Azura team for their dedication and hard work in planning and conducting the webinar successfully. And my heartfelt thanks also goes to the participants who took time out of their busy schedules to join us today. So, and their participation has made this session meaningful and impactful also. So, in today's scenario, awareness and education, that is again an important part, and it is playing a vital role also in preventing the kidney disease. In fact, it plays a vital role in every of the scenario, not only in the kidney disease. And nowadays, nutrition education is a very, very important tool and important part of the nutrition counseling, if I say, or any of the initiatives which encourage healthier lifestyle choices for the better health. And so stay healthy and take care of your kidneys. Thank you, everyone, for being the part of this webinar.
Thank you so much. Thank you. Bye. Take care.
Just to update one thing, that we have more than 220 logins today for this webinar.
Wow. Very nice.
Very
Yeah.
nice.
So that is like, you people have been doing great job. So people were really
Thank
interested
you
and
for
keen to
organizing
understand.
it so well, ma'am. Thank you.
Yeah, it's organized very well. Thank you.
Bye. Thank you so much.
Thanks.
Thank you so much.
Ruchi.
Thank you.
Thank you, Samru.
Bye.
Thank you.
Thank you. Bye-bye.
Thank you, Binu.
Thank you, ma'am. Okay. Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone.
Bye-bye. Bye.
Bye. नहीं नहीं इधर आ।